Good evening, everyone, and welcome to the November HOSC meeting. We've got quite a big agenda to get through tonight, so if we could go through as speedily as we can, with asking the necessary questions, of course. Not that I'd ever want to shut up, or even if I could. Have we any apologies?
Councillor Swaddle.
Thank you. Minutes of the previous meeting on page 5 in the agenda. Are you happy as I sign them as a correct record of the meeting? Yep. Any declarations of interest? No. Have we any public questions? No. Town and parish questions? No. Councillor questions? Let's keep going at this speed. We'll be gone shortly. Right. Have we got NHS online?
Not at the moment, Chair.
Do you want me to move on to adult safeguarding?
Do Health Watch and then come back to the service.
Okay. Is the Health Watch online?
Yeah, Alice is there.
Oh, Alice, can we jump to you, please? Because the NHS aren't online. I hope you're not sleeping there.
Oh, I hope not.
No.
I've waited.
Yeah, Alice, so can you give us your report, please? Nice to see you. Sorry you're not with us in person.
Well, yeah, thank you very much for seeing me, having me. I have shared with you all a report. I just wanted to find out whether there's anything that you want to ask about. I mean, as our activities have been, we've been very busy still, despite the fact that the rumors were going around that we were going to be shut down, but we are not going to be shut down until 2027, the earliest. So, so as you see, our priority work is still GP access, and I have shared with you all what our themes are, and access to services seems to be our biggest theme. And then we have also shared with you the dentistry. So though we all experience dentistry having access, but the ICB are doing a lot of work, especially for vulnerable groups. So the list that I have shared with you are groups that have been added on, including learning disability. Now, pharmacy awareness about medication wastage and prescription is also still part of the NHS app review as well. And that is something that it will continue to be seen. South Asian women's South Asian women and access to services is a report that we launched at our annual report launch and highlighted health literacy. So we are now still training community connectors to go out into the community to ask the community what part of the literacy do they struggle with. And we know from evidence, not necessarily the South Asian women, but in majority literacy, if we ever want to write an article or anything like that, it should be for the related to the age of 9 to 11. And then we also are continuing with public health with about women's mental health, because that is still a concern, because at 6 weeks on a check till the first year of a child's birthday, 18% of women die through suicide. And I mean, women's health is still a priority, and also what I'm excited about is because of the way we have championed it, it is going to be a priority in the new Thames Valley ICB. And then the youth voice, we are still our young persons are still doing showcasing that their needs by also making sure that their voice is heard, and they are really leading on this sexual health awareness. So they are working with Flora Clinic to look at the website. Our engagement has been ongoing, so you may or may not be aware that our team has been out and about doing the NHS app, trying to find out what are the people's issues about the NHS app, as the 10-year plan is looking at digital as a form of communication. And one of the things that has been highlighted to us is the awareness of the NHS app is higher. However, people are asking for support. And that has been the biggest challenge for us. Where do these people go to? We've been told the GP surgeries are the first place to go to. However, they are also stretched. So we are now looking at other venues that we can use for people to be accessing, to be shown how to use the app. But for that, we have to train community connectors to help them, because this is not something that you can sit in a session and teach people. It's got to be on a one-to-one basis. So that's going to be our biggest challenge now, even though the app is said to be the way forward, but there are people still being challenged with the access. Apart from that, the rest of the thing, I mean, I've shared with you all are the same things, but the new one that we've brought in is also the men's health. So we were planning to do men as carers, but what we've also had feedback is men are not attending appointments or taking the time to consider health checks. So we have been looking at that. Apart from that, anything else that you want to ask me, I'm happy to answer. And then the other thing that I've brought about is also looking at coding. Coding is caring, whereby if you go to the surgery, you are encouraged to be coded correctly. But we've been told that there has been some issues about the coding, not necessarily the surgeries, but cohorts not keen to be coded. So we are asking different organizations in Wokingham to work with us to identify the cohorts that will not engage and find out why, as well as showcase the benefits of coding. The rest of them, I mean, I'm told that you in the previous HOSC, you had learning disability come and talk to you about the closing the gap, and the feedback we've been hearing about having leads is ideal. However, we have found out it is not contractual. So we are still working on that to see whether there will be leads in each surgery. But we are told there are leads, but they're not necessarily clinical leads. Thank you. Any questions, please do ask.
Rebecca.
Hi Alice, do tell us
Hello.
the intel on women's health then. So what have you heard that Thames Valley have planned, the new ICB?
So I mean, we've been thank you, Rebecca, for asking. Thank you, Chair. For a while we've been asking why the women's health has not been on the agenda, and now it has been put on as a top agenda to look at what are the needs locally. I mean, to be honest, in Wokingham, we are quite privileged in the sense that public health has commissioned a service whereby, service to look at women's health as well. So, but the fact that women's health is on the agenda for the ICB, I mean, we have to wait and see what does that look like, to be honest. But the fact that it's there, I'm really excited, to be honest, because hopefully will be the same as what Oxford and Buckinghamshire's got.
Mike.
Hi, thank you for the quick gallop through. I'm a bit of a newbie on this committee, and I don't understand what the graph is right at the top of the paper.
So the graph is to show you what are the themes that we get from the public about the services that they're concerned with. So those are the graphs that we tend to share, because we always turn around and share what are the themes. So Health Watch is very much not about numbers, it's about the themes that we get. And access to services is one of the themes. Then we try and break it down to see what they are like.
Okay, so is a theme and a complaint the same thing?
No, a complaint is a different, a complaint is a theme.
Okay, and if I can ask, under engagement, you mentioned Norries, Arborfield, Shinfield, Winnersh, Woodley and Finchampstead, and I was kind of wondering why, with 30-odd thousand people in early hasn't been part of your engagements, particularly as we have just as many problems with access to health services, even though we're sitting on the doorstep of the Royal Berks. Is that going to be done in a later stage?
Yes, it is. But at the moment, the identification of these areas have been based on the Marmot findings. So, and that is where we have started it from. So there's the Marmot principals or the Marmot team has identified these areas as one of those areas. So we are just starting to go out there. So we thought this would be the areas we'll start with.
Okay, and under the 25-26 work plan, one of the things that I don't see there is anything about prostate cancer, which is one of the biggest killers of men in the UK and presumably in the borough.
So as the one thing that you will see is the fact that we are looking at men's health, and if they identify that, then yes, we will be looking at it. But the thing is, Health Watch is about looking at what access is all about. So if people give us feedback that they have issues getting checks, that we can look into that. So that is how Health Watch works. We don't, if people need to give us feedback that they are having issues with access.
Okay, so it's my understanding that some GP surgeries are very, very reluctant to commission a PSA test on request.
So, I mean, I'm happy for you to share that with us. If that is the case, please do share, because I've not heard that. But the thing is, I think if when we go out in January to look at the men's health, I think if that becomes a theme, then we can look at that. So I mean, November is Movember, so this is an opportunity for men to look at health checks.
Okay, there's a very good Reading prostate cancer support group that will probably give you feedback on that. I can give you the contact details if you'd like.
Thank you. Is that the Lions?
Sorry?
Is that the Lions, Reading Lions? They do prostate?
No, this is a specific group particularly concerned with prostate cancer.
Happy with that? Yeah, thank you.
Thank you.
Questions? Rochelle?
Is there any updates on the replacement of the hospital or moving it to a new place?
No update at the moment. It's still, we are looking at 2027, 2037?
2037?
Yeah.
Or moving it to a nice little area between Wokingham and Reading, so they don't have to go through Reading for ambulances during the rush hour.
I mean, at the moment, we haven't got any update of it because at the moment, because of the, I mean, that's something that you have to ask RBH. But as far as I know, that there's not been any development since the last announcement.
Okay.
Alice, I see Wokingham Medical Centre's come up on the report again. Are there still some access issues?
Well, they've got better, to be honest, but yeah, there have been challenges. I mean, there's still the surgery that has got issues, but there are other surgeries as well. Now Shinfields has come up as another surgery that there's been issues. But
so
yeah.
Is South Reading the other one? South Reading and Shinfield?
Yeah.
Oh, okay. Are you going to look at that again and report back?
Yeah, we will.
Okay.
We will. It's just the fact that at the moment we've got, I think the NHS app has become a priority because of because of the NHS 10-year plan. Yeah. As we go into the integrated neighbourhood partnership, because you know, as much as the desire is to the shift is going to digital, people are going to be struggling, because we're also hearing that people are worried about being scammed. How reliable are the data being kept? Or, you know, so there's a lot, but that's why I want to try and get digital champions out into the community to try and, you know, give people the confidence.
I've had a message from my doctor today to say your asthma checks are due. Please send in all your medical details, take your temperature, see how many times you can jump, you know, take your blood pressure, have you got all your teeth, all that sort of thing. So I didn't realise I was qualified to do that. I can do my injections all right, can't I, girls? Yeah. But has there been a change of attitude towards having patients in to do these checks?
I mean, as far as I know that, you know, I mean, like, for example, you know, they asked for blood pressure check. When was the last time you taken your blood pressure? They seem to be that way. But to be honest, every surgery is different.
Okay.
And, you know, and that is the thing. So that might be your surgery that's started to do that.
Perhaps they think we're all doctors in Woodley.
I think it's all about self-care, I think. And you know, that we are, you know, going forward, we will have to look at self-care. So prevention. So they want your readings a lot earlier, maybe. I don't know. But there are inconsistencies as how the surgeries are practicing at the moment. But there's so much changes, and my concern is there's so much changes in all this in the NHS that the public is still, you know, struggling to catch up.
Okay, thank you. Are there any more questions for Alice? Yeah, so Mike.
Just to follow on the point that the Chair made about asking odd questions, I've just had to go through a very lengthy questionnaire for my men's annual check-up-y thing, for which nothing has changed since the last year. None of my relatives have died of anything that could be remotely genetic, because they're already dead. So that hasn't changed, my height hasn't changed, etc. So I can't help thinking we're asking patients to put an awful lot of information in, which is kind of a barrier, because a lot of people say, oh, I can't be bothered. So we don't seem to be making best use of the information we have in our digital systems, and we're also putting an awful lot of reliance on people's digital competence.
Yep.
I note under your report about feedback on communication channels, etc. Well, what about those that are digitally excluded? Or you don't have a smartphone or can't actually get their heads around stupid questionnaires?
Well, that's why we are doing this NHS app survey, to find out what are the challenges. So my team is not only the surveys online, but they're also out and about getting feedback. So those are the things that we have been finding, that people, you know, are not keen to but access the app. But, you know, this is what the government is planning to do. But this is why we are trying to close the gap as much as possible to help the community. And you're right, in the sense that not everybody, but you don't have to have a smartphone. You can go on the websites as well. So that's it.
That assumes that you've got digital competence to go on a website in the first place.
But that is the thing, in a lot of ways. This is what the government has put out, so we have to try and navigate this, because there are, you know, whether we like it or not, that is going to be the future. So we need to try and get the public ready to, and that is what we are trying to do as Health Watch. That is what our role is, increasing awareness, but also holding services to account. But the only way we can do that is by getting feedback. If people share with us more about the challenges, the better for us. So, you know, we are asking, I mean, I put our newsletters and everything are going out, asking every organization that's around to invite us to their events, so that we can gather as much information. And I reach out to all the councillors as well. Please do share our survey, or invite us to any surgeries or events that you're doing. We are happy to come.
Okay, thank you. I mean, one of the biggest frustrations is the lack of joined upness between hospital records and GP records. Yeah. So with my NHS app, I can see what my GP's been doing, tests for me, etc., etc. I cannot access the Royal Berks stuff. if it's commissioned in the Royal Berks, which is daft.
Yep. I mean, that is the thing. If people give us, as I said, feedback matters. So, you know, the more people give us the feedback, the better.
Sorry, it seems to me that you're cutting out a vast majority of the people by saying they don't want to do surveys, they don't want to go on apps, and they don't want to. Half of them don't know what an app is, and half of them don't know what smartphones are even. So you're absolutely cutting those people out because you're not talking to the people. You're just actually saying, well, this is what the government wants, and we've all got to do it, whether we want to or not. I think you're losing an awful lot of the people in the country. I don't know what anyone else thinks.
Can I just say that that's what we are out there finding out, you know, and that is what we want to give back. We will have all these reports that we do and all the feedbacks that we get, we do share with the Integrated Care Board. So, you know, that is why we are out there asking people what are the challenges, you know, and how to close the gap. I'm not saying that, you know, we are only, you know, I'm not forcing people to do it, but the thing is we need to help them. And we also need to hold services to account to say to them that there are people who are challenged. I mean, according to data, there's only 20% of people who do not engage with digital services, but we are finding there are far more people. And that's why we're doing this NHS app. What are people's experience of the NHS app? And we are also finding that there are people who are turning around and saying there are too many apps. So that's also confusion with that. So that is what we are doing. We are trying to find out feedback.
Alice, is there a survey or something on your website that people can complete to put Kay's view?
Yeah,
Okay.
there is. I mean, that's not a problem at all. You do please go on the, I mean, the NHS app is also there. Please go on ours. If you go under news and reports, that's where you can put all the feedback.
Thank you.
But I have shared with as many people as possible the link to the NHS app. But we are happy to come up to the groups to have a conversation. And this is where the conversation has come up, saying that people are struggling with their app because they don't, they don't know how to access it, what the app is all about. And that's and I'm looking at different ways to try and get this gap closed. And I'm asking the ICB and also the surgeries to say, what are you all doing to close this gap?
Thanks, Alice. Rochelle?
Do we have any chance of having chemists do some of these tests that we need done, and having these people having problems with the apps, they could go to a chemist and they could tell them what you're actually asking for, and they might be able to test it, and at least they'll get some information.
You mean the pharmacist?
Yeah.
Yeah.
I mean, that's an option as well, but I have to see what the Integrated Care Board tells me as well. So I need to find out what are the services out there, because we have told that there are training services, sessions in the library, and there are also sessions in the surgeries. So and then I'm just waiting to see what else is there. I mean, we only started the survey, beginning of October, and we're already finding challenges taking place.
We're keeping you on your toes, Alice. That's all the questions for you, Alice. You're, of course, welcome to stay as usual. It's good to see you up there.
Thank you.
Have we still heard anything from the hospital? Okay, let's go on to adult safeguarding. Lorna, is that you?
Yes, it is. Thanks, Beth. So thanks for inviting me along to talk to you about adult safeguarding. Rather than try and whip through a load of slides, I prepared a report for you, which hopefully you've had an opportunity to look through and digest at least a little bit. I'm just going to pull some highlights out of the report, really, rather than go through it page by page, and then try and save the time for any questions or discussion points that you had. So on the basis that some of you are probably more familiar with adult safeguarding than others, I've just set out some of the legal context for you at the beginning, a bit of information about types of abuse and neglect. And then I've explained a little bit about one of the issues that confounds a lot of people, which is the difference between a welfare concern and an adult safeguarding concern. So if there's any queries on that, we can discuss that a little bit in a few minutes. I came to Wokingham in 2019, and when I arrived, there wasn't actually a standalone safeguarding service. There was a couple of posts kind of dotted about in adult social care. And my remit when I was employed was to review and then make recommendations for what was needed. Matt came along, I think, 3 or 4 months later, and by December of that year, we'd put in place our new structure, which started with the Adult Safeguarding Hub. And we built the structure around that, and certainly the feedback we get from other agencies and from CQC is that our structure is a very robust one. We were actually I think we were the first authority in Berkshire to create that kind of subject matter expertise in a team and to use the hub and spoke model. So the staff in the Adult Safeguarding Hub not only undertake safeguarding work, but they are able to act as advisors to everybody else in the system as well. Two of the really kind of striking things that have changed between 2019 and now that I've tried to pull out in there are about demand and complexity. Those are our biggest challenges, really. Since 2019, our rate of referral has gone up by 120%, and that's despite changing the way we do some things. So I would say, had we not made some of the changes we've made, that increase might have been closer to 130, 140%. At the same time as that really steep climb in numbers, the complexity has changed beyond recognition, really. And I think that started during the pandemic, where we had extended periods of isolation for people, and perhaps for some of those people, by the time concerns were then identified and raised with us, more and more people were in crisis, rather than that intervention coming at an earlier preventative point. Another real area of complexity in adult safeguarding is that we're working from a premise of autonomous adults. So adults have the right to make unwise decisions, provided they have the mental capacity to do that. So a lot of our work is not about just assessing a situation and putting a solution in. It's very labour-intensive relational work with a vulnerable person and with their network around them to support them as far as possible to take the actions to build protective factors and develop their resilience. So that can be time-consuming work if we're going to do it properly. I've touched in there on our CQC feedback, so you'll be aware that Adult Social Care had a CQC inspection back in March. We got a very, very strong good for safeguarding. We were actually only 1 point off an outstanding for safeguarding, so very, very close, not quite there, always room for improvement. The feedback was really positive, not only about our processes and our frameworks, but about our involvement of people in safeguarding, and very much about our continuous improvement loop, our learning from cases and translating that into service improvement. Towards the end of the report, I've just summarised some of our kind of most challenging and complex issues at the moment. So I've talked there a little bit about transitional safeguarding, where we are, what we've done, what we're hoping to do, and the same for cuckooing, which is linked to county lines drug dealing. I've talked a little bit about hoarding and financial abuse. So that's the quick summary. And really now, any questions, discussion points, anything that anybody would like to do a bit of a dive into?
Rebecca.
To be honest, it's amazing, isn't it, the amount of safeguarding concerns and reports that have gone up. It's 200%, it's huge. Now, that could be seen as a success for your service, in that you're allowing people to bring those concerns forward and they feel able to share them, and educating the people that are working within kind of with adults when there are safeguarding concerns, but it's still concerning. I mean, the one about neglect omission, that's one of your highest inquiries for type of abuse. Is that neglect, are you finding that, is that mainly neglect within people's own homes, or is that within residential properties that we potentially are involved with within the borough?
Sure. So it's a bit of both. I would say that the volume of concerns raised under that category probably sits within organisational care, so whether that be care homes, domiciliary care, supported living, etc. But with a heavy caveat, not all of those progress to safeguarding inquiry. So one of the things we have to do is we have to triage every concern that comes in. We have to apply those statutory criteria, but part of what we're looking at when it relates to neglect and acts of omission is this actually a practice concern rather than one of abuse and neglect? And what we tend to get is a lot of care providers who would rather err on the side of caution and raise it as a safeguarding concern rather than a quality concern, in which case what we will often do is divert it back out of safeguarding into case management if it needs our involvement, or we may just log it as a care quality issue, which we then monitor under a different framework. So whilst that category can look quite alarming, I think when you start to go into the detail, it's less so. One of the things that we have done with our structure to really support synergy between the safeguarding function and the care quality function is our care quality team is also based in my service. So we have really close joined up working between our care quality team and our safeguarding team, which means we can really focus on proportionate and supportive interventions. In lots of authorities, that care quality function will sit very separate in a strategic commissioning team, and it doesn't lend itself to as much flexibility. So that's something that we feel works really well.
So you're saying as well that because you're working together, if you're getting a pattern of certain practice kind of referrals within one place, if it is a quality issue, you can look at that, especially so more as a preventative.
Absolutely. So we monitor all of the intelligence that comes into our care quality team. So if I give you an example to sort of explain how it would play out, there are many, many medication errors in the social care and health system every day. You could not and should not deal with every single one of those as a safeguarding issue. But if, for example, we might get a medication error come in for a nursing home, and you look at it and in isolation, it didn't carry risk of significant harm. It was a very low-level thing, so you would log it as a care quality concern. But through our care governance framework, we monitor those patterns and themes. We have something called a care governance operational board, which has relevant professionals in it. If they will identify the pattern, and that will then trigger one of two things: either a proactive care quality visit to undertake a quality assurance exercise, or if the risk is fairly significant, we may actually trigger an organisational abuse safeguarding inquiry. So again, that co-location of the teams really helps that to be fairly seamless and dynamic.
Yeah, I was looking at that graph that Rebecca was just talking about, and I'm surprised that sexual abuse was such a small number of, a small percentage, or rather sexual complaints. And I'm just wondering how much is going unreported, how much of it might be buried in domestic abuse.
So The first thing I think to think about is that this data only relies to the adult safeguarding data. So that's where people have referred under Section 42 of the Care Act. So it's a group of people believed to have care and support needs. There will be, within our community safety partnership, there will be other data for people that are not eligible for a Care Act response, which will relate to sexual exploitation, to various different crimes that would fall into that arena, and more data on domestic abuse. In terms of the safeguarding data for sexual abuse, it's in line with both the South East and the national picture. Would I ever be naive enough to say I'm sure we get every single concern raised? No. But I am confident that sexual abuse and sexual exploitation is understood in the borough. And, you know, as with all other things, it's something we continue to kind of promote that awareness of.
Okay, thank you.
We've still got no NHS. It looks like they've had a better offer than us. So we'll carry on. Matt, it's you now with adult social care.
KPIs? Yes?
Yeah, sorry, yeah.
I mean, the first thing that struck me, I'm not going to, we're quite well versed here, aren't we, in bringing quarterly KPI reports. I'm not going to go through it in detail. I'll take questions. But one of the things that did strike me is this is just quarter one, isn't it? And I'm nearly through quarter three. So I don't know, is there a plan to catch that up at all? Because I was just looking at these indicators and thinking, you know, from my point of view, it was quite a few months ago now. So maybe we'll have a little look at how we catch up. Otherwise, you know, we'll be into next year looking at last year and things like that. So, any questions, really?
Mike.
Sorry, one of the things I hate about working digitally is you can't just flick pages over and see where you scribble all over them. You've got to try and find out stuff online. AS1B, assessment processes, you're achieving, well, in this particular KPI on quarter one, you're achieving 83% against a target of 64. This is due about summary of needs and eligibility determination completed for new customers within 16 weeks. It's rather good. So is this a national measure? Is one question one. The second one is, if we're that good at 16 weeks, should the time frame be reduced to see how good we are at, say, 12 weeks? Or is the 16 weeks some sort of statutory response period?
Short answer to that is yes. I must admit we've had different measures. Historically, we've had different measures on this, but we've gone with the 16 weeks so that we can benchmark. Yeah. You know, in reality, some things happen quicker, but sometimes situations are complex and it takes a bit longer. So, you know, short answer to your answer is yes. You know, it's we try to stick with the statutory indicator so that when we can, in the description, we can give we can benchmark. If we start doing our own, we lose that ability a bit.
Okay, thank you.
The AS4 is particularly impressive. You haven't even gone to amber, you've gone straight to green for 2 quarters. So what's been happening with the nursing homes, permanent admissions? Is it just a little bit of kind of luck on what's been happening, or is there kind of a real strategy to stop people being admitted?
I think it's yes to both of that. It is the honest answer. You know, demand ebbs and flows. Yeah. Obviously, when the trend here is up with an aging population, when they do jump up, we do redouble our efforts because you know, sometimes people need that sort of formal care, but you need to make sure that you're getting people home and keeping them there and keeping them independent as much as possible. So I definitely think the answer is yes to both, and probably a bit seasonal as well. Let's see where we are through the winter
hopefully
months.
it doesn't go straight back to red. You might get halfway.
you know,
you can't control a lot of it, can you?
No. But the reason we do keep an eye on that, though, is to make sure it forces that conversation about not putting too many people in care that's not required.
Because also I noticed the percentage of CQC registered providers that have gone down that are good or outstanding, which is slightly concerning with the amount of adult population we've now, with our ageing population, that homes are standards you feel are getting, well, they're slightly worse.
Yeah, I mean outside of that stat, I would say year on year it gets harder and harder as there are more and more people needing more and more care, and we have less and less resource, and the workforce is stretched. Another worrying thing for us is a lot of the adult social care workforce is quite close to retirement. There isn't a national strategy for replacing that, so it is getting harder and harder to maintain standards. That particular stat, though, will probably be to do with one or two. It's not lots, and also the fact that the CQC itself struggles to regularly inspect as well, which is an issue which we see.
Mike.
Sorry, can I take you back to AS2, please? Percentage of new contract referrals closed with advice, information and signposting. I mean, again, we're above target, pat on the back, but if you look at the graph from Q1 24-25 to today, this target is or this value is falling. So I'm wondering, are we going backwards in managing to help people through advice, or are we having to deal with more complex cases where advice just isn't appropriate?
Mostly the latter. I mean, Lorna said in her presentation, but that's kind of applies across adult social care. We are seeing more people with more complexity. Right. So volume overall more, but also more of those with more complexity. So I don't see that as a kind of service issue, that stat there. It's more reflective of.
It's a percentage of people, and yet the number of people has gone up. So I'm trying to understand whether we're being as successful as we were in terms of the absolute number of people that have been satisfied with advice, or whether there's something else afoot. We can have another look, and when we come back next time, we can kind of give another answer to that. But I don't think there's anything else afoot there. I just think that's the percentage, the right percentage for information and advice. Other people are needing more formal interventions. And it says we're 7th highest in the region, but 7th highest out of how many are in the region, please?
I'm going to say 18.
Oh, okay. Thank you.
Or 19. It's either 18 or 19.
Whether it was 7 out of 8 or 7 out of 78.
No. There's about I think it's 18 or 19 local authorities in the southeast region.
Matt, not particularly on this, but can you give us an update on the new care home? Is it ready to go? Have we got people in it?
The which one? The Hollies. Yeah. Well, again, another short answer. Are we ready to put people in it? The answer is no. We've still got quite a bit of work to do on the refurbishment, and the quality of the care we inherited. It's not quite where we want it to be, so we're having to spend quite a bit of time bringing that up to scratch. My latest prediction on that, although it does depend on works being complete and us being happy, is that in the new year we will start to take new clients. You know, and the other thing is, what, you know, we definitely learnt this from Bluebell. If occupancy is lower for a period of time, which we planned in the business case, it's easier to do refurbishment. It's quite difficult to refurbish a nursing home when there's lots of people in the nursing home for obvious reasons. You know, people doing building works and people needing nursing care. It's not a happy match from a logistics point of view.
If it goes as well as Bluebell has, and as you know, we learned from very close experience earlier on in the year, we'll be very proud of it. Yes, Mike.
Me again, I'm afraid. Going back to AS4 about the number of permanent admissions to residential and care homes. It's a bit grim, but I was kind of wondering what the churn figure is in care homes, because if we're admitting, we have a target of 23 and we're admitting a bit more than that. Does that mean we've got 23 coming out the other end, so to speak? Is there a constant churn figure? And is there a finite limit to the number of people we can actually deal with, or is it a question of just, if we can't house them in our own homes, we just have to farm them out into the private sector? Complicated, I'm sorry.
Yeah. So, well, we don't solely use our own provision, although we've bought that capacity because it helps us manage care and budgets, you know, to the best of our ability. But we also commission in other private homes as well that also do a good job. Definitely, there is, you know, people pass away and that frees up space. What I would say is, in COVID, a lot of people died in care homes, and occupancy went right down. Occupancy in care homes now, you can see, I think you can see from the table, has come right back up to pre-COVID levels. So it is an issue, you know, not just for Wokingham, but that more people are needing particular nursing and dementia nursing care than there are available spaces.
This obviously ties in with something I would have asked the NHS had they turned up, because an awful lot of beds are blocked in hospitals because there's no suitable care environment for people to move into. At least I get that impression from some residents' comments. You know, that's that factor of churn and affordability and suitability and a whole bunch of other really complicated.
Yes, I mean, why, you know, why you get those demand pressures on the NHS is quite a big topic for conversation. I think solely reducing that to there aren't enough care home beds is way too simplistic. I would say, you know, investing in adult social care and concentrating as much on that as investing funds in the NHS is something that would absolutely help with that, but doesn't always happen. I would say that. My public health colleague here would definitely say, and be right, that the real solution there happens way before people get anywhere near to a hospital, in terms of increasing population health and focusing much more on that and investing in that, rather than waiting once people need social care in the hospital. You know, it's too late to prevent some of that. But it's quite a complicated question. But I think simply reducing that to care homes in terms of capacity issues in hospital is very simplistic. It's multifactored.
One of the things from the action tracker from March 2025, an update in the future around sources of funding for new hospital or maintenance was requested and to be scheduled, but any idea when it's going to be scheduled to happen? Any idea of any kind of possibilities of doing any of these things, especially with the government probably being cut funding, and what's going to happen with that? Most of the predictions are that the government is presently going to cut down funding on most things, if possible, in the near future. And how will we deal with that in health?
That doesn't fit into this item.
I know.
Because we're looking at adult social care. So perhaps we could put that on another agenda and have an update.
Yeah, that would, if we have a date for it, at least have an idea of when they can tell us something or not tell us anything.
All I can say is don't hold your breath.
I wasn't planning on it.
Is there anything more for Matt?
Only one final question. The great set of KPIs, it looks as though we're doing really well, which I think we've got that from the CQC reports, etc.
We're just going on to KPIs.
Okay. Yeah. Well, I'm just wondering what other ones we should be looking at.
Beth, can I just interrupt for a second? I've had a message from Melanie. Sorry. It's not working. I've had a message from Melanie. She's stuck in the car park outside and can't get her key out of her car to lock it. So she's giving her apologies. Sorry about that. We could all go out there.
It might be useful.
I need to tell you a story. I was with her on Saturday night when this same thing happened, and the AA had to be called out, so there is nothing you can do. She has to wait 20 minutes, and it might kind of reignite or... Brand new. Well, not brand new, but she only had it a day.
There's always a tent out there if she needs a nap.
She's community.
Yeah.
What kind of car is it? I want to not get that.
Yeah. Are there any more questions on adult social care for Matt? Okay. Let's move on to the KPIs on page 81.
I can't speak for the NHS, but I will do the bits that we're contributing. I'll just shut the...
Jyoti, can you put your mic
on?
Oh, sorry.
Rochelle, could you turn your mic on?
What about my slides? You can't? But people have them in their... You have the slides in your packs. Okay, that's good. Let me find them in here. Okay. So you will know that cold weather can have a direct and indirect impact on health. Directly, it can increase, apart from respiratory illness, which I'm sure you will all be familiar of, the risks of cold weather and respiratory illness. It can also increase risk of heart disease and strokes, cardiovascular risks. And of course, you know, when it's icy outside, people are more likely to fall over and injure themselves. And if they can't heat their homes, they're also at risk of hypothermia. But alongside those direct risks, there are also indirect risks in that it can cause, cold weather can cause disruption to our health services, etc. You know, the ability for people to move around, transport. And cold homes can also be associated with poor mental health and poor educational outcomes, etc., and employment success. And there's also a small risk of carbon monoxide poisoning. In terms of who's at risk, of course, those who are over 65, but also those who are very young and under 5, people who've already got existing long-term conditions, cardiovascular disease, respiratory or mental ill health, pregnant women and people with learning disabilities. People who live at home alone and aren't able to look after themselves might find it difficult to get food in, you know, the things that they need to maintain daily living. And they may experience, people who have difficulty paying their bills might find it also difficult to heat their homes, or of course those who are sleeping rough will experience the ill effects of cold weather. We've been working with our NHS colleagues to promote the NHS flu and COVID-19 vaccination offer, as well as the pneumococcal offer. We've used our WBC corporate channels, and we've also used various means to target those who are most at risk. We are doing a session with the voluntary sector group on Thursday to raise awareness of winter pressures, about vaccinations, where people can look for resources, and to keep an eye out for those who might be vulnerable and offer support where it can be of benefit. We'll also be putting out messages about how to keep warm, how to work with others, so working through emergency planning and others, as I said, voluntary sector, to keep an eye out for those who need it and offer the support and to signpost. We'll be putting out any national alerts that we receive through UKHSA and working with our partners, as I've said, to just make sure those messages are out there. I'm happy to take any questions that you might have.
Hi, JT. There's been some recent press about the high levels of flu, especially in younger adults and children, and obviously the impact that has on passing it on to our older relatives. Do we know what the kind of where we're at locally within the borough as uptake?
I've not seen any data, but I can look it up for you and get back to you. Yeah, but you're right. I think it's probably going to be a difficult flu year, and so pushing vaccination uptake, both in the young and the elderly, is a really important thing to do this year.
I think as well with the COVID-19, there's a lot of people that think, even though it's around, they don't want to have the jab anymore. I mean, trying to persuade my parents to have it this year. I think
there's vaccination fatigue, isn't there?
Yeah, they've kind of had enough of it, and they don't want to have both of them done at the same time because I'm going to feel rough. But, you know, luckily they have had it done. But I think there is a little bit of that now.
Well, any help you can give as councillors in your community to promote uptake, I think, would be really valued.
Some people just don't feel they need to have it because they had somebody in the past.
My apologies, my key was stuck in the car.
Yes.
This may or may not be relevant to what we're tonight, but I notice here winter communications and engagement plan, right? And down here it says encouraging patient flow through the hospital. Does that mean the patients in the hospital or people who are going to their doctor and then being guided through the...
I think that might be part of the NHS presentation.
Pardon? Aren't we on this one?
No, but JT can't answer it.
Hmm? You can't answer
I'm
that.
talking about the public health contributions. I think that there's also an NHS presentation, but they haven't arrived to deliver it.
Oh, well, I can ask. Okay.
But I would expect it's about making sure that people aren't sitting together for long periods of time and that people are passing through so that they're not exposed.
Right, well, it is relevant because it happened to me this last week, and I want to know, I want to know what is the norm. So, shall I wait?
Probably I can't answer it. I'm not sure what your question is, though, either.
Okay.
I think you're asking the wrong
Person. Okay, thank you.
it was unfortunate. I had most of my questions prepared for the NHS presentation, and I was really annoyed by having a 7-page interpretation for all the stupid acronyms they used. It just seemed to me just lazy and not writing it out properly in the first place. You talk about winter vaccinations and promoting the NHS offer of flu and COVID-19 vaccinations. It's not very easy. It's not necessarily easy. So I got a text or something from my GP surgery saying, book now. It wasn't particularly easy to book. When it took place for flu, it was super efficient, in and out in minutes, along with dozens and dozens of other people. But COVID-19 vaccinations are only available to a very limited cohort, it seems to me. And even as a volunteer in the hospital, with some vulnerabilities, I can't access a COVID-19 vaccination. And I suspect I'm not the only one. And if you want to be able to keep the hospital operating successfully, you need all the staff healthy. And if you're saying, okay, you can only have a vaccine if you're extremely vulnerable or you're over 75, is rather missing probably about 90-something% of the staff in the hospital. So it's my question, I suppose, is how can we make it easier for people to obtain access to these vaccinations?
That will be based on national policy, so there's not much I can do to change that, I'm afraid. We will, most of us will have some immunity if we've already had COVID, and I think there will be some general immunity, and the top-ups are about protecting those who are most vulnerable from having very adverse outcomes, effects of getting the disease.
I suppose my concern is people are becoming complacent about their resistance to COVID. And therefore, when they've got some sniffles, headaches, and all the other features of it, they're not necessarily self-isolating. They're not necessarily trying to stay away from pubs and clubs and restaurants and crowded trains and buses, etc. So we're getting transmission in the community again. And I've had no end of people in the last few weeks saying, oh, I've just had COVID. Okay. Hasn't particularly affected them badly, but it is taking, they're infecting other people, and it's affecting the efficiency of things like throughput in hospitals. So I do think it's slightly short-sighted. I don't know whether we as a committee can write to central government saying, please do something different.
If I could add to that, because I just qualified for over 75, and I had them both at the same time, and I spent 4 days in bed. So I think you're better off without them, to be honest.
Can we scrap that from the notes, please?
Yeah. Had a lot of chicken soup.
The ill effects of actually getting flu would be much worse. They'd wipe you out for a week or two, or could even kill you. So.
Okay, let's have a look. Have we got anything else? Have we got to the end of the agenda? Forward programme on page 81.
Okay, sorry. So you'll see we've got 2 additional meetings in December. So the first one is GP performance and GP access, and health checks. We had a query raised about when we're looking at the public health KPIs in terms of NHS health checks, so we've got a whole item on that. And then on the 17th of December, we have a one-item meeting for the care and support framework. So moving on to January, you'll see it's a pretty busy meeting. Going from what Matt said, we will try and obviously regularise the adults' KPIs, because at the moment we've currently got Q2. Some of the items are time critical. One item the committee may or may not wish to keep on the agenda is the alcohol, tobacco and vaping needs assessment. That's coming to the Wellbeing Board within the next week. So you may wish to see the outcome of that discussion before you make a decision on that one, would be my suggestion. And then moving on to March, again, that's quite a busy meeting with some quite heavy items. I would suggest you've got community pharmacy and dental services. As you'll be aware, the ICB are becoming Thames Valley ICB, and that's March meeting is quite near where that's all going to be happening. So you may want to defer those two items to the June meeting to give them the best chance to give their resources to you. But we still obviously have weighty items in terms of Marmot update, in terms of the council's work on becoming a Marmot borough, and we're obviously also hoping for an update from South Central Ambulance. And you will have hopefully seen early in the week that obviously they've merged from a admin point of view as well, so they'll have probably lots to update. So as you can see, you've got quite a lot already on the agenda, but is there anything that any members want to, I'm not going to say come on if something else comes off that we've got, or would like to raise for something for the new year, because we've still got some unscheduled topics.
Given that we haven't had the NHS presentation on winter preparedness, can we find space for them to come back and tell us how well they did with all these, because there's reams of management speak in the 30-odd slides. And actually what really annoys me is that on the first slide it says we've been given money to increase capacity, and the next line says there's no increased capacity, which seems to be slightly contradictory. So we're not going to have time to fit in the how well they're doing as preparedness. Can we have a how well did you do? What lessons have you learnt? What are you going to do differently next year that we can help with in the borough?
Madeline will follow up with them about why they weren't here. Yeah, and then we'll see where we go from there. Anything else? Thank you very much. A much shorter meeting than we anticipated. Have a good journey home.